Всім, хто нас дивиться вже, і поки ви доєднуєтесь, я вам нагадую відповіді на самі популярні запитання. Так, запис цієї події буде. Він буде і українською, і англійською на каналі доктор Булавінова. Зараз ми йдемо на 3 площадках. Ми йдемо в Zoom, в YouTube і на Фейсбуці координаційного центру. Тому ви можете дивитись нас на 3 площадках. Якщо в когось не спрацьовує Zoom, то йдіть дивіться туди. В нас працює переклад. Там є такий глобус, ви можете нажати на нього в Zoom і ви будете слухати канал, наприклад, український, або ті, хто хочуть це слухати на англійській мові, ви будете слухати на англійській, і потім запис доступний на обох мовах буде. Тому хто як що любить. Зараз я чекаю, що в нас буде сигнал, що всі зайшли, і потім ми будемо розпочинати. Зараз. Ага, все, в мене є сигнал, що люди зайшли на Zoom. Тому, пані Оксана, вам слово, ми розпочинаємо.
Друзі, вітаю всіх! Вітаю всіх учасників. Я Оксана Zbitneva, керівниця координаційного центру з психічного здоров'я Кабінету міністрів України, директорка всеукраїнської програми ментального здоров'я «Ти як?», ініціативи першої леді України Олени Зеленської. Я сьогодні готувалася до нашої зустрічі і неймовірна цифра, з якою я маю з вами поділитися. Це наш 22-й вебінар в межах спільного проєкту з дитячим фондом ООН UNICEF та Європейським товариством дитячої та підліткової психіатрії, яке очолює пан професор Fegert. 22-га зустріч неймовірних людей. Чому неймовірних? Тому що, не дивлячись на повітряні тривоги, якусь нескінченну холодну зиму, коли ми були без світла, без тепла, ви приходите на ці зустрічі вживу, в Zoom. Потім, звичайно, є багато тих, хто переглядає в запису. Але ось середовище, яке створює атмосферу зустрічі, воно є неймовірним. Іноді я сама собі кажу: Боже, люди добрі, у нас 7 година вечора. Та що вас може тягнути до того комп'ютера, до гаджета, щоб під'єднатися до Zoom, якщо це можна подивитися в запису? Але люди йдуть. На сьогоднішню зустріч, до прикладу, зареєструвалося 1213 учасників. Ми зараз бачимо 226 лише в Zoom. Це те, що ми бачимо. Я вам всім вдячна. Вдячна за те, що ви з любов'ю робите свою роботу. І вдячна за те, що ви не пропускаєте тої можливості десь взяти знання, запитати те, що бентежить з тої вашої практики, в якій ви щодня. Що ви дослухаєтеся до порад, що ви кидаєте ці мільйони сердечок, які для нас є підтримкою. Тому з величезною вдячністю і повагою до вас. І пан Фегерт, з вдячністю до вас. Цей марафон вже в 22 вебінари, де ви по всьому світу шукаєте для України найкращих експертів дитячої підліткових проблем, а головне рецептів вирішення цих проблем. Це неймовірно цінно для нас. Дякуємо вам. Мені здається, в нас сталося, знаєте, більше, ніж робочі стосунки, і ми дуже за це вдячні.
Пан Фегерт – це любов. Тому, пан Фегерт, вам слово.
Thank you very much, Oksana. Really thank you for your very kind words. And I must say, last week I had the chance to speak to President von der Leyen in Brussels, because she asked me to head a new committee on social media in adolescence. And I told her that we now have more than 20 webinars. You know, she's supporting with some of her prize money from the Charlemagne Prize, our webinar series now in the second year. And she was really impressed that so many people attend these webinars during these very, very difficult times. And I described to her that sometimes the numbers go up and down corresponding to the air raids and the horrible context you are living in. And I told her that it's so admirable how professionals in Ukraine try really to do the best for the people they care for. And that's, we are really full of admiration. And today, it's my special pleasure to introduce to you Professor Elisa Pfeiffer. Elisa Pfeiffer is a professor of clinical psychology and child and adolescent psychotherapy at the Catholic University Eichstätt-Ingolstadt. Could you mute the mic, please? And she heads a scientific working group on trauma in children and adolescents, also still at my department. I'm especially proud to introduce her because she was trained at my department. And now she is a professor with her own chair, but we are still in connection. And for example, 3 weeks ago, she organized a meeting with the Ukrainian delegation because she organized trainings in trauma therapy for Ukrainian specialists. And we met all together in Ulm. She's very active together with another colleague that had been trained also at my department, Professor Cedric Saxes. She did several studies together with him. And I will no longer steal your time. Elisa Pfeiffer, it's up to you, but it's really a pleasure to have you here. And we're looking forward to your talk.
Виводьте, будь
Wonderful.
ласка, да. Виводьте, будь ласка,
Перепрошую,
спікера.
пані Еліза.
Так.
Перепрошую. Зараз професор Фегер. Так, щось сталося? Ні?
Да, пані Оксана, ми вас чуємо, кажіть.
Ага, зараз професор Фегерт сказав важливу річ, на яку я маю відреагувати, тому що якщо ви, пане Йорк, по запрошенню голови Єврокомісії будете очолювати комісію спеціальну комісію по соціальних мережах, для нас буде важливим від вас дізнаватися, що рухається, що як відбувається, і будете готові поділитися з нами, і коли ми будемо готові поговорити про соціальні мережі в середовищі фахівців, боже, чийсь такий вискочив екран, не знаю чий, то ми будемо за це дуже вдячні, тому що це питання хвилює всіх і в Україні. Дякую.
Всім нагадую до того, як спікер почне говорити.
But now it's up to Elisa Pfeiffer with her talk. Thank you, Oksana.
Всім нагадую, що можна буде задавати питання в чатику, і я в кінці буду їх зачитувати, а пані Елайза буде відповідати на них. Все, просимо вивести спікера і презентацію на екран. Дякую.
Wonderful. Good evening, everybody. I'm very delighted to be here today. It's an honor for me to speak in front of so many wonderful Ukrainian colleagues. Thank you so much for taking the time to be here today. I want to thank Professor Fegert, UNICEF and ESCAP, and Oksana from the bottom of my heart to invite me here and to give me this opportunity. I really appreciate it. Thank you very much. Today, I was invited to talk about evidence-based trauma-focused treatment for children and adolescents. And before I begin, I want to take a minute to thank each one of you here in this call, to thank you for your amazing work with Ukrainian families every single day. I hope you know what a huge impact you have by caring for children, adolescents, adults every single day in Ukraine. And I want to thank you from the bottom of my heart for that. And I do hope that from what I'm allowed to talk to about today, that you can take some of the information and it will be useful for your everyday work in Ukraine. Let me briefly tell you what I planned for our session today. I'll first start with some basics on trauma, trauma-related disorders, and then I'll briefly talk about assessment of post-traumatic stress symptoms in children and adolescents, and then we'll talk about the main topic today, evidence-based trauma-focused treatments, what treatments are out there, and we will focus on one treatment in particular, that I will describe in a bit more detail, just so you get an idea of what those treatments actually look like in implementation. And we implemented this treatment already in Ukraine. I do hope that I see some familiar faces here today from TFCBD Ukraine from our project. And I'll talk a bit about implementing those treatments in Ukraine, what we've learned from our projects. And in the end, I'll briefly talk about something that is very important to me. What about the therapists? Because the therapists that I work with in Ukraine, and many of you, probably most of you, are also living in a war context and have to have this struggle in your personal life every day as well. I look forward to your questions. As it was mentioned, please write them in the chat. I will make sure that we'll have half an hour in the end, so we have enough time for your questions. All right, let's talk briefly about trauma and trauma-related disorders, what I mean by that. What can be considered a traumatic event? A traumatic event, based on the definition of the DSM-5, similar to ICD-11, is the confrontation with an actual or threatened death, serious injury, or sexual violence through either direct exposure, witnessing the event, or learning about it. And when we look at learning about it, it's really actually hearing from a very close person of mine that experienced this event, and hearing very detailed, a lot of details about the event. So it's either the traumatic event, for example, can be from sexual violence, domestic violence, interpersonal trauma, up to accidental trauma. And I'll talk about that really briefly as well. We categorize, this has been there since the 90s, but we still do categorize traumas a bit on two dimensions. One dimension is a type 1 trauma and a type 2 trauma. So the type 1 trauma is that this event happened once, like a car accident, for example, is always a good example, or a one-time robbery or a one-time sexual abuse. And then type 2 trauma is a repeated traumatic event. So for example, domestic violence with a lot of traumatizing episodes of domestic violence. And in the context of Ukraine, obviously there's a lot of interpersonal trauma and repeated trauma given the war context, and I'll show some data later that we had collected on frequent traumatic events in children and adolescents in Ukraine. We do know that these types of traumatic events have different consequences, and this is some data from research, so this is really not based on the very individual, but the average of children and adolescents. So we do know that type 1 trauma is often followed by symptoms that are usually very clear, very vivid recollections of the event, and children and adolescents may develop the full clinical picture of PTSD. The primary emotion is fear, and the treatment prognosis is generally very good. So we have a lot of responders in our trauma-focused treatments. Type 2 trauma, so for example, ongoing physical and or sexual abuse, or sometimes both types of abuse. Related symptoms after type 2 trauma are often rather diffuse recollections of the event, of the different episodes of the event as well. A strong tendency toward dissociation, attachment disturbances, and in children, adolescents, and also adults who experience type 2 trauma, and especially interpersonal trauma, there's higher rates of complex PTSD. Very common emotions in type 2 trauma are shame and disgust and guilt, which are, in the context of trauma, very powerful emotions as well. We do know that these emotions have a very strong impact on symptom development, but also manifestation. And we do know that type 2 trauma, interpersonal trauma, is oftentimes a bit more difficult to treat and can be a predictor of non-response. What are trauma triggers? I know trauma triggers is or triggers, the word by itself is very common also in youth language. In Germany, I learned it a lot from the patients I personally see. They come into my practice. I'm at the head of an outpatient center, and they say, I have so many triggers. And then we discuss on what is a trigger and what are your trauma triggers. What I mean by that is trauma reminders. So external, internal reminders that remind me of the event and that produce physiological, emotional stress reactions. Those reminders or triggers can be external, so places, people, smells that I smell can remind me of the traumatic event, or images. They can be internal sensations, for example, just a heartbeat racing because, for example, a child has an exam coming up and they're very stressed and nervous, and this physical reaction reminds them of what they felt during the traumatic event, which may lead to intrusions and stress reactions. Triggers can also be situational. For example, being trapped in an elevator could remind me of a traumatic event in which I also had the feeling of being trapped, or also seeing news on TV about, for example, war scenes and bombings can also be a trigger for me to be reminded of my event and elicit a fear response. Related to traumatic loss, so losing a closely related person to me, a beloved person to me, very sudden or very violently. Common trauma reminders related to losses are oftentimes situations in which a patient or a child adolescent feels a special emptiness, which reminds them of the loss, or different rituals, for example, the birthday of a beloved one. And me as a therapist, I'm mindful of those triggers when I treat children and adolescents with trauma-focused treatments, and sometimes I have them develop different trauma trigger lists just for them to be more mindful and understand a bit more what is happening in those moments, that it's normal for them, that their unconscious or their consciousness reminds them of the trauma, and that it's normal to have a stress reaction. But it can be helpful for patients to be aware of those triggers, to be able to understand what is happening. And in trauma-focused treatment, we want to reduce the stress response to those triggers. Common signs and symptoms after trauma, so directly after trauma, are oftentimes being disoriented, shocked, fearful, even like a freeze response, a lack of sense of control and safety, which is why we often want children and adolescents right after an attack, a bombing, or another traumatic event to gain control, to feel safe where they are, as safe as it is possible in the Ukrainian context right now. They often feel a lot of helplessness and uncertainty. In smaller children, we do see regressive behaviors, such as being more clingy, crying, and then we always see oftentimes some PTSD symptoms, such as hyperarousal or intrusions, that could then manifest into PTSD, full-blown PTSD. And oftentimes children in my outpatient center, where I see a lot of acute trauma patients, they also report somatic problems like lack of energy, sleeping problems, or headaches. So I want to invite you to, when children come to you, also if you're in primary care and they report headaches, stomach aches, or loss of appetite, to maybe also be mindful whether that could be trauma related. Typical signs or symptoms after traumatic loss are, for example, the difficulties in continuing with the normal life. Yeah, and now I'll briefly take you through PTSD. I'm sure most of you know what post-traumatic stress disorder, PTSD, looks like. I'll just want to do a quick catch-up. So after a traumatic event, and PTSD is the only mental health disorder in where the issue where we know where it comes from. So we always know it's a trauma, and that leads to symptoms. We always need a trauma for a person to be diagnosed with PTSD. And then the first symptom cluster of PTSD is intrusions, nightmares, flashbacks. In children, we often see a lot of intrusions or stress, physiological, emotional stress reactions when confronted with trauma triggers. We see a little less flashbacks. What is also particular in children and adolescents, the nightmares don't need to be trauma associated. In adults, yes. In children, no. They can just be any nightmare. And in smaller children, we would see traumatic play, for example, where we enact the traumatic experiences in play, which can be very disturbing for parents, actually, when, for example, an abuse scene is being played with the kid with different toys. That is very difficult to understand or to for parents, but it's basically some form of intrusions or re-experiencing. The second symptom cluster is avoidance, avoiding different places, situations, conversations, thoughts on a traumatic event. And then we have the symptom cluster of negative alterations in cognitions and in mood. So, for example, more anger, less positive feelings, dysfunctional post-traumatic cognitions. So, for example, cognitions related to the world in general. The world is not a safe place, or cognitions related to others. Everybody could be a perpetrator, or cognitions related to self. My life is ruined. I'm a broken person. Those post-traumatic cognitions often develop already during the traumatic event and persist after traumatic event and manifest. And we do know that those post-traumatic cognitions are predictor of post-traumatic stress symptoms. Also, on the hyperarousal cluster, difficulties to concentrate, hypervigilance, sleeping difficulties. So basically, children are generally more stressed, more alert, which then leads to sleeping problems and concentration problems. I'll talk about this only quickly in order to have enough time to talk about treatment. So we do see there's a lot of evidence-based risk and protective factors in development of PTSD. There's general risk factors like interpersonal trauma and general vulnerability, but also during and after and just before the traumatic event, there's different risk factors that might be helpful to keep in mind when assessing trauma. And it's very important that children and youth have enough social support after a traumatic event, because we know that's a very strong protective factors to not develop symptoms. The prognosis of developing PTSD, these numbers are pretty solid. We just had a new meta-analysis that came out last year that also showed these very similar numbers. So after experience a traumatic event, 50% of children and adolescents are resilient, do not develop PTSD or trauma-related disorders. 25 to 30% can be categorized as recovery, so they might have some symptoms but then recover without any treatment, and only 15% develop chronic PTSD. We do know interpersonal type 2 trauma are those children who experience that kind of trauma have a higher likelihood of developing chronic PTSD, and then late onset is way more prevalent in adults compared to children and adolescents. So it's children don't have symptoms after the event, but months, years later. And this is a slide that I stole from Mr. Fegert that I love very much. I showed it in every presentation on trauma-focused disorders. This slide, I just want to highlight that the trauma-related disorders that children and adolescents develop after traumatic event are very much age and developmentally based, need to different based on age and developmental stage of the children and adolescents. So in small children, we would see more often regulation disturbances. Sorry, could you mute the one person? Thank you. And then in youth, we see more often also substance abuse disturbances and personality development. Okay, so that's the basics of trauma and trauma-related disorders. I hope you could follow me on that part, and I know many of you had already learned much about those topics. I briefly want to talk about assessment because it's really important for me and it's really part of trauma-focused treatment. We start with assessment and we end with assessment. Assessment helps us in identifying the children and youth who need trauma-focused treatments. So after having them complete a questionnaire, and I will present the questionnaire in a minute, and after our clinical impression of the children and adolescents, we can, in a way, for that very situation, for that day, for that week, in a way, categorize them into 3 different categories. The bigger group will be resilient, so no symptoms or no clinically significant symptoms. A smaller group will probably have mild, moderate symptoms, so they might have re-experiencing symptoms or some avoidance, but maybe not hyperarousal symptoms, so don't fulfill criteria, or all of that. They do have PTSD symptoms, but they're not clinically relevant, so they don't have like a functional impairment. And then there's the category that you can see in red. I made those colors a bit like a traffic light. Red is children who report PTSD symptoms who would fulfill criteria. And both the yellow and the red can benefit from trauma-focused treatment. In the yellow group, we might, if possible, offer rather maybe a group-based intervention, a low-level intervention, and in the red category, we would offer individual trauma-focused treatment. One measure that I want to share with you today is a child and adolescent trauma screen. I'm sharing this questionnaire not because I was part of the developing team, but really because it's freely available. You can just download it and use it. It has a clinical guide that explains how to use the measure and how to report the results to children and adolescents. I also put the link on how to access it on the bottom of the slide. And I know the slides will be shared later, so it might be easier to copy that out of the slides. And this is a very child-friendly measure. So this was really developed for children and adolescents and not just taken from like adult research and changed the wording a bit, but this was really developed for children and adolescents in the US and Germany and Norway. And in the Netherlands, we validated in all 4 countries, and now it has been translated to many languages. And there is even a meta-analysis just on this measure on how the validation is. But what is content of this measure? So it assesses potentially traumatic events, and I'll show you that in a second. There's a list of 15 traumatic categories of traumatic events that the child can easily just tick boxes. I experienced this or I did not experience this, which is maybe oftentimes a bit easier for children who experience trauma, instead of having oftentimes the therapist that they haven't met before. When a therapist asks, so did you experience anything traumatic? That's sometimes difficult to share their experience with this person that they're not familiar with. But to just complete this questionnaire and checking a little box, yes or no, that is oftentimes much easier for children. And it's a good conversation starter for the therapist and the child. On the second page of that screener, the post-traumatic stress symptoms are assessed. They are based on DSM-5 and ICD-10 and ICD-11 criteria. And then we also measure functional impairment, because for a diagnosis of PTSD, you always need functional impairment. There's 3 different versions. There's the self-report for children who are 7 and older. And it says on the slide 7 to 17, but I'm using this measure also with 25-year-olds. So it's okay to use this measure when kids or youth or young adults are a bit older. Absolutely. And then there's a corresponding caregiver report. So the parent or the grandma or maybe a teacher who knows the child well can also help us by rating the symptoms and experiences that the child experiences. This is often very helpful to have 2 different perspectives. And then there's a version for small children, 3 to 6-year-old or just younger than 7. It's based on DSM-5 preschool subtype that is only completed by the caregiver. This is the measure. On the left side, you can see it's a Ukrainian measure, and you can see the event checklist. And on the right side, you can see the symptoms. And online on the website that I just shared with you, there is also attached just a guideline on how to rate the items and how to like understand if the criteria would be fulfilled or not. What I want to mention is that you can see like a list of potentially traumatic events, and here children can tick a box on whether they experienced it, but this measure does not assess the frequency or intensity of the traumatic event, or, for example, the perpetrator or when it happened. So it's really just, did it happen? Yes, no. So for us to learn a bit more about the traumatic event, it's very nice to use this measure with the kid and say, would you like to tell me a bit more about this event? Let's talk about it. I'm here for you. Okay, that's all I wanted to share about assessment. This questionnaire is available for you to use, and it has a clinical guide attached that helps you in how to use it and how to implement it. And one thing that I want to add is that we highly recommend, and when you have a family, a child, and a parent complete the questionnaire, please make sure you always give them feedback. You always thank them for completing it, and you provide them with feedback on the results, because it is very, in a way, disturbing for kids if they disclose their experiences and then no reaction follows. So they're like, so why did I disclose it at all? So always make sure you discuss it with the family. All right, now let's talk about trauma-focused treatments for children and youth. I want to start with a little timeline on the different trauma-focused evidence-based treatments that are out there. They started to be developed and evaluated in the 1980s, and I'll talk a bit about the individual treatments in a minute. But as you can see, there's only been like 40 years of research on those protocols. And first, there was a lot of different protocols or treatments developed for adults, and only later, a lot of those treatments were adapted for children and adolescents. And in the 1990s, TFCBT, trauma-focused cognitive behavioral therapy, was developed and validated, and that treatment is particularly developed for children and adolescents. I'll talk about that treatment as an example a bit more in a minute. Okay, what I want to share with you though real quick is, and I spare you all the statistics and all the research, but I want to show you that there has been a recent network meta-analysis that showed that there's a lot of studies out there on trauma-focused treatments for children and adolescents, and they have high effect sizes, so they work very well. We do see that there's a lot of studies on cognitive therapy, so CBT-based programs that are very effective, particularly the TFCBT program that I'll present in a minute. And in this study, we also saw that group-based programs are effective in reducing PTSD. These are the treatments that I want to share with you today. Those are the ones with the most evidence for children and adolescents. So there's, I'm sure many of you know some of these protocols. I know that several of them are now being trained in Ukraine, which is amazing. PE, CPT, EMDR. I know there's initiatives for all those treatments in Ukraine now, which is great. Let me briefly introduce them, and then I'll talk about their commonalities, but also differences. So the first protocol is PEA, so prolonged exposure for adolescents, by Edna Foa and her group. That is a treatment that has been there almost from the very beginning. It was one of the first PTSD treatments, and that has been adapted to adolescents. And this treatment is really mostly about exposure and repeated exposure. The cognitive therapy by Perrin and colleagues is mostly disseminated and evaluated in UK. This treatment really focuses on post-traumatic stress, post-traumatic cognitions that I mentioned earlier in my talk, those cognitions such as my life is ruined after the trauma, that are very crucial in development and maintenance of PTSD. And we know those cognitions are a change mechanism in PTSD treatment. So we know that if you address those cognitions or those cognitions change through treatment, that is one of the mediators mechanisms that also reduce PTSD symptoms. And that therapy really tackles those cognitions, similar to CBT, cognitive processing therapy. That was by Rezik and colleagues in the US, which also focuses very much on those cognitions. KidNet, so narrative exposure therapy for children and adolescents. Narrative exposure therapy was developed by a German group here in the south of Germany, so very close to where we live. And that's an exposure-based therapy that has great effects also in crisis regions and in regions that have very low, don't have a big mental health care capacity, and that can be implemented by lay counselors as well. And that has been just adapted a bit for children and adolescents. It's also mostly exposure. And then EMDR, I know EMDR is trained in Ukraine as well. EMDR is not CBT based, and it's about bilateral stimulation when talking about a traumatic event. And then STARE-NT is a treatment that is pretty new for complex PTSD, developed by Marilyn Cloitre and her group, who is also the founder of complex PTSD, now in ICD-11. And that is a more a modular-based approach where there's more stabilization and then exposure. And TSCBT, I'll talk about that a bit more now. It was specifically developed for children and adolescents, has a stabilization phase and then exposure. The differences of those treatment protocols are really the evidence. So there's not many studies on CBT or KidNet, for example, for children and adolescents, many more in an adult field. And there's, for example, more than 25 randomized controlled trials on TSCBT, and there's a growing evidence base on the effectiveness of EMDR in treatment in adolescents, which is extremely promising. The doses, so the number of sessions, varies quite a lot between those protocols, and most of them or almost all of them are short time treatments. So there's this myth that trauma-focused treatment always takes very long. Especially that's a myth in Germany. I'm not sure if that's also a myth in Ukraine, and that it takes a year or longer, but we do know, but all of those protocols are like 6 to 24 sessions. So they're quite short. Most of my trauma-focused treatments, and I'm implementing KidNet, EMDR, and TFCBT, are only several months, in which we meet on a weekly basis. STARE-NT is a bit longer. It has more sessions and more modules. It's the longest of all of these treatments. They also differ on how much they include the caregiver. So if you work in a child and adolescent field, I'm sure you know how important it is to incorporate the caregivers. And we do, and especially TFCBT incorporates them a lot. The target populations differ a bit in where TFCBT was developed for sexually abused children, but now we know it's effective for all kinds of traumas. And KidNet, for example, is often used in crisis regions. Okay. How do evidence-based treatments resemble common treatments for traumatized children? They are just like any other treatment. The therapeutic relationship is central. It's very important also in trauma-focused treatment. And similar to other therapies, the therapist's creativity and clinical judgment is very much valued in those treatments, and flexibility is important. And different cultural, religious, developmental concepts are respected and integrated. Now, let me give you an example of one of those treatments. TFCBT, I'll only say the shorter version now to save a couple of minutes. TFCBT is a hybrid treatment model that integrates trauma-sensitive interventions, cognitive CBT-based principles, but also family therapy or humanistic therapy. The age range for that treatment is 3 to 18, but I've also already offered this treatment to young adults, and it's highly effective and helpful. The manual of this treatment is also published in Ukrainian. I couldn't find a picture to put it here, but it's available in Ukrainian, the treatment manual. For whom is TF-CBT appropriate? For youth with trauma, with trauma-related disorders, children with prominent trauma symptoms, children with severe behavioral problems also benefit from this treatment. And we want to involve non-offending parents or caretakers in this treatment. And yeah. Now let me give you a brief overview of this treatment, just for you to get to know the model. So it's a short treatment of 12 sessions, but every session is 90 minutes, which is in Germany, that's like 2 sessions. And it has 2 sessions because it's 1 session with the child and 1 with the caregiver every single week. So the caregiver plays a very important role in the treatment, and is our I always say the caregiver is my second therapist in supporting the child during treatment, helping the child employ those techniques that they're learning, like a breathing technique, also at home, to practice at home. And our treatment is short, so it's very important to have a caregiver who understands the situation of the child and the trauma of the child, to be with the child also after our treatment. The treatment itself has 3 different components. The first component is coping strategies. So we do psychoeducation, relaxation. We talk about feelings, intensity of feelings, different feelings, how I feel them in my body, and how I can change negative feelings. And then we talk about cognitions, thoughts, and how to change those thoughts. And then the main part of this treatment is the trauma narrative, the exposure. So we write a narrative, a story about what happened, and we incorporate feelings, cognitions, and this is the exposure part. So we want them to feel stressed in order to make the experience that it's okay to talk about it, and they will learn that every time they repeat the event and talk about it, it's easier for them to talk about it. And then we do some cognitive processing. So if there's a lot of thought cognitions on guilt, shame, we would address them in that part of the treatment. And the last part is an in vivo exposure, and then a combined parent-child session in which the child reads the trauma narrative. So the experience is also to the patient, and we talk about it together. And before that session, we read about it entirely with the parents, and they are prepared from us, from the therapists, to support that child in sharing their experiences. And then in the end, we want to promote safety and security. Let me briefly say a few words on psychoeducation, because I think that no matter in what field you work, that is something that everybody could find helpful and could apply on every single day. So the psychoeducation, which we also do in every other CBT-based treatment, is really to teach or to teach a child on about the trauma, but also PTSD, what is normal, what is not normal. And the main goal is to normalize, so to explain to the child that experiencing a trauma is not normal and not that common, but the stress you feel after that and the symptoms, that is a normal reaction to a not normal event. So it's normal to have intrusions and scary thoughts after you experience a traumatic event. We want to explain the stress reaction. We want to explain that it's normal to have difficulties in sleeping after a traumatic event, and that is related to the context and situation. We want to explain the trauma triggers, that it's also normal to, when you're reminded of the event, that you feel stressed. We want to provide them with a sense of safety and control, which they already do when we explain to them that it's a normal reaction to have sleeping problems. That gives them a sense of control, because sometimes children don't understand why they have difficulty sleeping after that experience. And we do want to already start changing maladaptive cognitions or myths like I will never have a good life again, for example. And when we do offer trauma-focused treatments, we can instill some hope to the child and family that they can be optimistic that there will be a recovery, just because we know that those treatments are highly effective. Okay, how do I do it? As a practitioner, I provide them with general information. So what is a traumatic event? And what are examples for traumatic events? How often does this happen to other children? How often do children and adolescents experience this in your city? So there's oftentimes numbers that we can share with them. So because a lot of children feel alone, they feel like only sexual abuse will only happen to them, nobody else had this experience. But for them to learn that just based on statistics, we know that 3 other kids in that from the 100 kids in their school level probably experience something similar. We want to provide information about very common emotional and behavioral responses, and to feel stressed when being reminded, or that it's normal to avoid talking about it. And we want to emphasize positive coping. So we want to ask them, what helps you when you're reminded of the traumatic event and you feel stressed, which is normal? What do you do? What helps you? And they say, well, I watch TV or I go outside, and we try to work with them on different coping skills that could be helpful. We might use sentences such as, unfortunately, a lot of children experience sexual violence. You are not the only girl experiencing this trauma. Or many children have trouble falling asleep after experiencing war in their hometown. Or what you experience is a normal reaction to an abnormal situation. Or there is a treatment that can help you heal. So those trauma-focused treatments, for example. I also like to use metaphors, and in my work with Ukrainian partners, I learned so many more new wonderful metaphors, but I want to share one with you that explains very well the exposure part of the treatment. The wardrobe metaphor, is it called? So as you can see on the left side of the screen, it's a full, very packed closet with a lot of stuff chaotically thrown in there. And once we pass that closet, it's just like everything just falls out, and everything is very chaotic, which is very similar to traumatic events. So that is how a traumatic event is saved in our brain. It's very chaotic with a lot of feelings. So for example, the sweater in that closet is the fear that we experience with a traumatic event. The pants are, for example, the traffic light that I saw through the accident, and it's all very chaotically organized in our brain. And what we do in exposure is we do open that closet and organize those memories. So when we pass the cleaned up closet, nothing will just like be thrown at us, but we can open the closet and nothing bad will happen. I sometimes use pictures like that, or the wound metaphor for when you have like a wound a wound on your arm, for example, because you fell from a bike, and if you don't treat it, it gets worse and worse. But if you put some desensitization on it, it hurts because it hurts, but then after that it can heal. And putting like a desensitizing spray on it hurts, but after that it can heal and you might feel better. I want to highlight here that parental involvement in psychoeducation is important. We want to help parents normalize their own reaction and the child reaction in the context of war. Because I think parents or grandparents with whomever the child lives or is a close person to them can promote resilience. They can create a familiar routine. They can promote a sense of self-efficacy, of safety, enhance playfulness, limit exposure to media. I think they have a very important role. And I want to highlight that parents are the experts for their children. Let's empower the parents and grandparents and involve them in psychoeducation and help them understand the child's behavior, feelings, emotions, and help them, and maybe especially in the Ukrainian context, understand what are my symptoms, what are my experiences, and what are the symptoms of my child. They don't need to be similar or the same. They can be very different. And how can I help myself in order to then help my child? The Ukrainian context, and I'm in Germany, so it's very obviously it's not I can fully understand what everybody in Ukraine is going through. I want to mention that very clearly. This is really only from what I learned in 4 years of working with Ukrainian therapists, is that context in Ukraine is very different, where you have the continuous traumatic stress or the experience and impact of living in contexts of realistic and ongoing danger. So when we in Germany do trauma-focused treatment, most kids are safe. They're not in an ongoing traumatizing situation. And there's this aspect of shared traumatic reality, which I just mentioned with the parents. The whole community might experience this traumatic event, but also the caregiver and also the therapist might live in a traumatic reality. So how would we tailor such a treatment like TF-CBT to the Ukrainian context or to a context with ongoing trauma? First, we as trainers asked ourselves, well, what would we do if we weren't doing TF-CBT? If you don't offer treatment, PTSD becomes chronic. So we recognize that for many children, the primary trauma is past and not ongoing trauma. So we want to learn with the patient what was the trauma in the past and what is happening right now. We want them to learn to discriminate. And in TF-CBT, we would treat, or in any other trauma-focused treatment, we treat the past trauma and give them coping strategies and a safety plan for ongoing trauma. We want them to understand what is a trauma in the past and what is a trauma reminder. We want to prioritize safety, so we would do the safety session in the very beginning and provide them with safety strategies. And they already have a lot, but just to like maybe add to those strategies, like what do I do when I'm in danger? What is a dangerous situation? How can I understand how dangerous the situation is? And what is my action plan? So what do I do when there's an air raid? What is my plan? And I know that's not news to all of you in Ukraine, but sometimes it's helpful just to like write that down. What is my action plan? Frame it, and just for them to feel like I have a plan when something happens is very important. And I know most kids do, obviously, but that is something that we would also discuss in therapy. We want to engage, validate, support parents, and help them understand their traumatic reaction, but then also their kids' traumatic reactions, and provide them with helpful parenting strategies. During the exposure, during the trauma narrative, we would adapt that in a way that we help them gain perspective on what is an ongoing danger and what is a constant danger. We want to help the child differentiate between trauma reminders and danger, and we want to increase parental insight. And what I find very helpful is for us to work together with the patients on separating the cognitions. So in a traumatizing situations, I might have high fear and fear of dying on the one hand, but on the other hand, I can do an assessment of how dangerous is the situation really. Because a lot of situations feel extremely dangerous, but they might not be that dangerous compared to other situations. We want to help them understand and what is my emotional reaction and what is like a rational the dangerous level of the situation in order for them to be a bit more confident in categorizing the current ongoing threatening situations, and sometimes learn for some situations it's not that life-threatening compared to others, and to feel less stress in the less life-threatening situations. I want to briefly mention some research that we did on TF-CBT Ukraine. Our study that we have done now for quite some years. We started in 2022, right after the large-scale invasion. I was lucky enough to have some amazing partners in Ukraine, for example, Vitaly Klimchuk and many others who I was in contact with. And I wrote an email to the developers of TF-CBT and other trainers, international trainers. And we very briefly built a little group in which we developed a training model for Ukrainian therapists. And we were very fortunate, together with our Ukrainian international experts, to offer trauma-focused training programs in Ukraine. You can see there's a lot of partners involved and a lot of funders, which was amazing. And I want to highlight our team of translators. We had amazing translators who have been with us since 2022. And I always tell them, now you are ready to teach TUCBT yourself, because they translated so many of our sessions. We implemented a training program, so the therapists would do a web training or read the manual, then receive a 3-day basic training, and then treat patients themselves. And during the time that they treat patients themselves, they would receive supervision, and then they would be certified if they complete all those steps. And we offered a lot of extra sessions, such as on traumatic grief, on assessment, on how to change TUCBT for ongoing trauma. And also we offered a program which with the name Practice What You Preach, a self-care program for our therapists, an 8-week self-care program for them to apply techniques that they might find helpful when treating others with trauma. And we translated all the materials in Ukrainian. I'll be a bit brief on that. We saw that there was a very low dropout rate of that treatment in Ukraine, which was very impressive to us, given the context that there's a lot of mobile therapists, but also patients, power outages and everything. But we had low dropout rates, similar to RCT studies, high manual adherence. So therapists were able to follow the manual despite giving them the complex context and often complex symptomatology. The treatment was offered in both digital and in-person format, sometimes starting in person, switching to digital. We also then had an extra session on how to implement it digitally. There was really no problem in recruiting patients. There are a lot of our therapists who worked in private practice and NGOs, in hospitals and schools in very different contexts. None of the therapists had problems in finding therapists. And we did have some adaptations that I just display on this graph, but I won't be able to talk much about it given my limited time here today. But to summarize it, there were not a lot of adaptations necessary to train and to implement this treatment. I want to give our therapists a voice here. We did amazing interviews with our therapists. And one of the therapists said, when we asked our therapists about the challenges that they experienced, sometimes we just can't continue therapy. When the city of Dnipro came under frequent attacks, the boy's father had just returned from captivity, and they were immediately advised to leave. So they left and they moved to a remote village with hardly any internet. Another important thing that we need to keep in mind is that the war is ongoing. I mean, we process a traumatic experience and then it recurs. The child reads the news. By the way, children read a lot of news. Even at the age of 10, they distinguish between different types of missiles, Shaheeds, and some other projectiles. And then they slip back into that reaction, even though we have processed the previous event. The war is not over. During exposure in the midst of war is a new experience. More on a quantitative data collection side, we could include more than 300 patients. So the therapists were invited to send us the CATS questionnaire pre and post for us to see whether it was effective, the treatment. And the most common reported traumatic events of the children who received TUCBT were war, bullying, witnessing and experiencing family and domestic violence. But as you can see, there's really high rates of traumatic events next to the war. And what is very promising, we saw that on average, the symptoms significantly were reduced after TUCBT, and those effect sizes are even higher than in studies in Germany or Norway. So we see that this treatment is very effective in Ukraine right now. Similar results we found for EMDR, which is not a trauma-focused treatment. Maybe some of you are also trained in EMDR. Similar effects, and we just submitted that paper, it's not published yet. Very high effects that patients on their self-report, but also parent-reported really improve. So what about the therapists? We did some assessment of the therapists in our program on their professional quality of life, and we saw that they had an average high compassion satisfaction and low burnout and secondary traumatic stress rates. And those numbers on burnout and secondary traumatic stress are much lower compared to German and Norwegian therapists. So we were just incredibly impressed with the resiliency of Ukrainian therapists and of their strength. But although we found those amazing results of the resiliency of the therapists, I want to mention, obviously, therapists live in ongoing traumatic situation, and that self-care therapist is crucial. It's important to also help the helpers. Keep in mind that therapists and mental health care providers and healthcare providers also need self-care and need support. I know many of our therapists worked in 2 or 3 different places of work. They had a high workload and then also family, which was so impressive to me. I often ask them, how do you do all that? Which was very inspiring to me. And we need to be mindful that we also need to take care of our mental health staff and healthcare staff. And we did a program, the self-care program, we had high and good effects on that as well. So with that, I think I'm finishing almost on time. I want to thank my teams in both Ulm and Ingolstadt very much. Without them, all of this work is not possible, and all the patients and therapists who participated. And I especially want to thank each one of you for being here today. I see that it's 370 people listening, joining in. I can only echo what Oksana said in the beginning. It's incredibly impressive that you're taking the time to be here today in your evenings to listen to me. I feel very humbled by that. Thank you very much for being here today and for your amazing work every single day. I look forward to your questions. Thank you for your attention.
Пані Оксана нас слухає, але вона не може до нас зараз приєднатись. Але вона нас слухає в цьому ефірі. Тому розпочинаємо з запитаннями. І професор Фегерт, коли ви захочете втрутитись у відповіді, будь ласка, втручайтесь. Зараз хвильку. Я йду до початку запитань. Так, зараз хвильку. Так, перше запитання від пана Сергія Марієвича. Значення шкали ТАСС-20, шкали Торонто чи PHQ-9 мають значення в даному опитуванні чи ні?
You said task 20 scale, right? Did I understand correctly?
Шкала Торонто чи PHQ-9 або шкала ТАСС TAC-20.
Yeah, thank you for this amazing question on assessment. Wonderful. I absolutely agree. I also like to work, for example, with PHQ-9. It's always important to assess not only trauma, PTSD, but also depression, anxiety, all kinds of other mental health disorders, because as you saw on maybe this one slide that I stole from Mr. Fegert, children and adolescents develop very different trauma-related disorders. It's not trauma equals PTSD, but a lot of children who experience trauma may develop anxiety, depression, substance abuse disorder. So thank you for highlighting these measures. It's always great to assess not only PTSD, but also other symptomatology. Thank you very much. There's also a website, International Trauma Questionnaire, that has a lot of measures that are translated into Ukrainian freely available that might maybe be helpful as well. PHQ-9 is one of them.
Питання від пані Людмили Лісінчук. Яким чином доказові травмофокусовані втручання можуть бути ефективно інтегровані у роботу з дітьми, які перебувають у стані хронічної травматизації? Наприклад, через війну, коли травматичний стрес не є подією минулого, а триває в теперішньому.
Yes, thank you for that question. I'm sorry, I only had one slide on how to adapt it to the ongoing context. It was a bit brief on that part. I want to mention that for a long time, there was this idea internationally to only offer trauma-focused treatments to those kids who are safe, who are not in a traumatizing environment, who don't have any contact to any perpetrators. And there is now a shift in that perspective where we see that a lot of children and adolescents who experience ongoing trauma, already have severe PTSD and are not treated. They are not helped just because they experience ongoing trauma. So now actually our study is one of the first studies that investigated whether those treatments are effective in ongoing trauma situations. There's not a lot of evidence on that, but we do have some evidence now in TSCBT and EMDR. And how do we adapt it? As I quickly mentioned, we want to treat the past trauma that they had already experienced and give them coping strategies and a safety plan for ongoing trauma and future trauma. So we do, in a way, separate those experiences, and we do know that doing exposure or treating the past traumas reduces PTSD, although they might experience new trauma, and it can be protective for them to have this experience of, it's okay for me to talk about it. I can learn to talk about it. It gets easier and easy for me, which is something, a learning experience that they have through trauma-focused treatment that helps them, and also talking about other traumatic events, and they learn coping skills, for example, breathing techniques, emotion regulation techniques, cognitive techniques that could help them in reducing stress during ongoing traumatic experiences.
Пані Альона Трилецька питає, які є курси для українських фахівців зараз?
Yeah, there's different initiatives that I know of. There's an initiative from different international groups, but also local groups that implement training programs for STAIR, EMDR, NET. Our project unfortunately just ended. We unfortunately ran out of funding, so we cannot offer any more training programs, which is extremely frustrating. It has been a bit difficult to get funding for more training cohorts. There's a lot of international trainers waiting happily to implement more trainings, but we are currently looking for funding opportunities to continue this program. So if you're interested in being participant of that training, please maybe check my website. We will announce if there's new training abilities. And I want to mention that this whole project was moved to our partners at University Zaporizhia, so it's in local hands. So we have a trainer, Natalia Mossel, who took over the project because we wanted, as international experts, to pull back a little bit and have Ukrainian trainers train Ukrainian therapists, because they understand the Ukrainian context much better than we do. And Natalia has been amazing in training more and more therapists. So I hope that together with her, we can find funding opportunities to offer it again. Fegert, yes?
Yes, I think we should build up a waiting list, because I talked to several persons to ask for funding, and they are still in the decision process. I also went to the Ministry of Foreign Affairs, but that's not their thing to do it, but they might be supportive. But if we have a list of how many people are waiting for the training, this is always quite impressive. So perhaps if that colleague in Ukraine or you collect a waiting list and show me the names and the numbers of people that are waiting, perhaps we will convince people to fund more training, because I'm really impressed what you did with your initiative and how many therapists you could train. So if I can help, I would try to do my best.
That is very kind. Thank you so much. Absolutely. I'll start that waiting list and make it available to the participants of the webinars as well. Thank you for that idea.
Пані Олена Грузін просить порекомендувати опитувальники.
So next to the CATS questionnaire, which is trauma and PTSD, your colleague already mentioned the PHQ-9, which is, I think, available in Ukrainian as well, that assesses depression. I also recommend the International Anxiety Questionnaire, International Depression Questionnaire, which are both on this website that I mentioned, International Trauma Questionnaire, because they are also already freely available and translated in Ukrainian. And then I'm not 100% sure what other measures are already translated into Ukrainian, but they summarized all the different measures. And as I mentioned briefly before, it's important to consider other trauma-related disorders when a child experiences trauma, such as also substance abuse in youth, or personality disorders in youth, or in smaller children, regressive behavior, and then in school children, for example, also externalizing symptoms like ADHD symptoms that can also be trauma-related. So it depends on the case, but my approach at my outpatient center and also in Ulm, every child who comes into our treatment centers would sit down for like half an hour and complete a lot of questionnaires on different symptomatology just for us to not miss anything and for us to see where, in what area symptoms are most dominant. So I highly recommend that. And then have the same questionnaires again at the end of the treatment for us to see whether there was a significant change or the child might need even sometimes maybe more treatment.
Пані Людмила Лисинчук питає, як адаптувати доказові травмофокусовані втручання для дітей з нейророзвитковими особливостями, наприклад, аутизмом, які мають труднощі з вербалізацією емоцій та травматичного досвіду?
Great question. There is some evidence that TFCBT also has good effects on ADHD symptomatology, actually. But a lot of the efficacy studies of TFCBT excluded children and adolescents with autism spectrum disorder. So there's less evidence on the effectiveness of those treatments, on all trauma-focused treatments on children with autism spectrum disorders. But there is an English implementation manual on how to adapt TFCBT to children with autism spectrum disorders. Maybe I can quickly, next to the next question, I'll look up that link and share it here. It's an implementation manual that guides you through that. And I know you're all very good with translation, so just put it into Google Translate and you'll have a wonderful manual on how to adapt the treatment as well.
Пані Анна Кисіль питає, чи в цих підходах є поправки, певні нюанси при поєднанні з фармакотерапією?
Yes, so there is international treatment guidelines and do not recommend pharmaceutical therapy for PTSD, but so for example for comorbid depression that can be helpful, and then maybe a severe ADHD can be helpful medication next to TFCBT for them to be able to follow the protocol and to benefit from it. If I have patients with ADHD or severe depression, sometimes I wait until they have medication for them to then be able to really benefit from the treatment, but most often it's a parallel process. But I need to, as I'm a psychologist, I'm not a psychiatrist, so I'm aware at least of the side effects of those medications and have think of whether those medications might have a negative impact on treatment outcome or treatment progression. I need to be mindful of that. But maybe I figured you're a psychiatrist, maybe add something, please.
Yeah, I absolutely share your remarks. There is no evidence that psychopharmacotherapy is helpful in this treatment of the core symptomatic. There has been a big study at NIMH, and it failed to prove that there is an augmented effect in therapy. So if there are other symptoms to treat by pharmacotherapy, of course, but I think there is no expectation that pharmacotherapy adds something substantial to the therapy of these patients.
Пані Олена Кудаєва питає, підкажіть, будь ласка, як ви опрацьовуєте ту частину процедурного алгоритму, де треба створити безпечне середовище для травмованої дитини, якщо це неможливо. Наприклад, дитина постійно проживає в умовах активних бойових дій.
Yes, Very important question, and that is not something that we as international trainers could teach, right? So we could teach that that's what a therapy room should look like, closed doors, them feel safe, or that's how you do it digitally, where there's no other person in the room so they can feel safe. But then we learned from our Ukrainian therapists on how they were able to still develop those safe spaces in which, for example, one therapist shared they actually did the treatment in a shelter, but then put like little blankets around their self-created therapy space and made sure they were in a corner, for example, or in a part of the bunker where not a lot of other people could listen in, and that they were very mindful of just for them, the two of them feeling safe and feeling okay in that at least a little safer environment compared to what we would want them to feel in a therapy room. So there's, I think there's a bit of a stretch in how safe that environment is, but then the therapist is very much responsible and in our project very successful in just providing that sense of control and safety just for the therapist being present, being available, listening, being mindful of the reactions of the child, which also made them feel safe in a obviously not safe general environment. Absolutely.
Пані Марія Курта питає, чи підтверджені дані про спадковість травми у людей?
Yeah, and no, I think Mr. Fegert can answer that question actually better than I can as a psychiatrist. So I'm a little shy in answering the questions when you are in the room. So if it's okay, I would give you the floor.
Go ahead. It's your talk.
So there is quite some good evidence now on epigenetic changes through trauma, from mom's trauma being in the epigenetic changes in the child due to the high cortisol levels that a lot of traumatized people have. That high cortisol stress levels are sometimes inherited to children as well. And what I want to say as a psychologist is oftentimes parents who experience trauma talk about those experiences to the child and left aside all the genetics and epigenetics that also has an impact on children. And a lot of trauma survivors are especially very strong characters and people because they also grow out of those experiences, and that is also given to the children, where they often are also very strong characters because their moms and their dads are models for them in growing from bad experiences.
I think it's very important to have that psychological aspect because if you see it like a self-fulfilling prophecy, that doesn't help you in that situation. I think after the war, the Second World War in Germany, there was a whole generation that didn't speak about the traumatisms, and that had consequences for generations. But at the moment, we don't know what this war will cause in Ukraine for the families and for the children and the grandchildren. There will be research and support, but I'm sure that the fact that people are able to speak about it and that there is a shared and common understanding of what is going on is very, very helpful. So please don't fear too much that it's in some way encrypted in the genome of the children. You know that epigenetic things really have to be expressed under certain conditions, and that the environment and the caring environment and the relationship to the child plays a very important role on the possibilities of the child to grow up and for its development. So don't see it as a self-fulfilling prophecy that these children will have future problems. They can have a bright future, and we have to work for that.
Thank you.
Пані Польшикова Дар'я Наскільки ефективною може бути робота з підлітком із ПТСР, якщо батьки звернулися до спеціаліста, але самі не готові брати участь у терапевтичному процесі? Брак часу. Як у такому випадку будувати втручання без батьків?
That's a great question. We do see that involving parents and caregivers can be difficult because it's a lot of time for them. It's a lot of emotional stress sometimes also to come in every single session with the child. And we have a lot of youth who don't want to have their caregiver involved because they say that's my treatment and my therapist, and they want to be autonomous and focus a bit more on peers than on their parents. So it's also for youth, sometimes they don't want to have the parent involved, or especially in sexual abuse cases, they don't want to share that trauma with their parents. So I always try to involve the caregivers as much possible, and sometimes that incorporates some negotiations with the youth. For example, when we share the traumatic event, they would not share the entire event, but only parts of it, things like that. But we do know that it has a positive impact just from like science to have the parent incorporated in TFCBT, but it's also effective without a caregiver, or if the caregiver is only involved, for example, in one session in psychoeducation, or if the trauma narrative is not shared. And I want to mention that as I presented all these other trauma-focused treatments like EMDR, KidNet, all of those treatments don't incorporate the caregiver that much. So often they only do psychoeducation with the caregiver, but don't share the trauma, or don't do parental skills, or don't do emotion regulation strategies for a mom and also for the child. So it's really TFCBT that incorporates the caregiver very intensely. Those other protocols don't involve the caregiver that much, and they're also highly effective with youth and with children. But I personally, and I'm sorry for the long answer, but I have such amazing experiences myself as a therapist with involving the caregivers, especially when sharing the traumatic event, because that is often sometimes that nobody talks about in a family. And in that safe environment, there's the possibility to actually talk about what happens in a, not at home, but in a different room with a different person who moderates that conversation. And after that, oftentimes, the family relationships change a lot, because now we talked about the one thing that we don't talk about normally. And I'm sorry, Mr. Fegert, I thought that you wanted to say something. I'm done now.
Yeah. Yes, but I just wanted to add and refer to your own research. If we compare the long-term results of therapy, of trauma-focused therapy in children, overall they are better than in adults. And I think the parents play an important role to maintain the results, because they have got an understanding of what's going on, and they can really intervene in a positive way to maintain the positive results. So it makes absolutely sense to involve the parents, because they are the primary caregivers and they can support the children.
Absolutely. And sometimes it just helps to talk with mom, dad, grandma, and the child about the worries they have, and not incorporating the caregiver. So what are the exact reasons? Being scared of talking about the trauma with them, having a bad relationship with mom, and on a lot of those reasons, that's actually part of therapy to work on those.
Пані Тетяна Каміно питає, чи працюють доказові травмофокусовані втручання з прощенням кривдника?
That is a hot question, I need to say. That is something that a lot of people have strong opinions about, so I love that you raised that questions. The number one question is oftentimes, do we involve the perpetrator, yes or no? If the perpetrator, for example, is dad who beat the child in the past, that is, I personally have good experiences in involving the perpetrator parents if they are have a perspective on where they, for example, feel bad about what they did, and they don't hurt the child anymore, and they want to find a way to work through that with the child to, in a way, apologize. if we don't involve them, which is normally more the case. So for example, sexually abused children, girls who experience sexual abuse from a peer, from their boyfriend, we normally do not involve them because we only involve adults. And the treatment is not about forgiveness, but finding a way to live in the same world as the perpetrator, because a lot of kids see that perpetrator at school every single day, and we want them to find a way to cope with seeing that person as a trauma trigger. And what I do find sometimes helpful as a strategy, but that's also highly debated, is to write a letter to that perpetrator that we never send. It doesn't leave the therapy room, but after the trauma narrative, after the exposure, for them to just say what they always wanted to say to that perpetrator in a letter that we then, for example, burn, or that we put into the trash, whatever, but to just say those few words that they always wanted to say to the perpetrator. Those are often very empowering sentences, like, for a short time you wanted to ruin my life, but I can tell you now you didn't succeed. I'm strong now and I will survive you. It's your fault. There's no guilt on me. Sentences like that are incredibly powerful, but we don't push the patients to say those words or to have that perspective. That is oftentimes a very long process, also after therapy, where a lot of, especially I had a patient, a girl that had experienced sexual violence, and it was very hard for her to not feel guilty about what happened. Very difficult, even after trauma focused treatment. She still said, it's 20% 20% is on me that this happened. And I saw her a year later and she said, now I understand, I have zero responsibility for what happens, but I just needed some more time. So guilt, shame are very strong feelings that often need very long time, and we don't want to push or force or have a very strong opinion as a therapist on that, because that's really the patient and their cognitions, and we just want to help them live, as I mentioned in the beginning of this, apologies, very long answer. We want them to help find a way to cope with the traumatic experience, and we don't need them to change a perspective on the perpetrator, but to be able to live with what happened.
Нас 335 на Zoom, зараз 14 на YouTube, 11 на Фейсбуці. Це дуже дивно, бо вже 8:45, але всі продовжують дивитись. Будь ласка, підписуйтесь на канал доктор Булавінова, де ви можете знайти запис цього ефіру, а також записи всіх попередніх ефірів на українській і на англійській мові. І останнє питання на сьогодні від пані Олени Кудаєвої. Можете окреслити основні засади впровадження груп підтримки для дітей та підлітків з ПТСР?
There's several group-based protocols out there that are effective. For example, teaching recovery techniques, or CBITS, which is an intervention from the US, that are highly effective and that can also sometimes be implemented by so-called lay therapists, so school teachers who are trained in that manual. I'm not aware of a manual that has been translated to Ukrainian yet, I'm afraid, but those group interventions can be highly effective for children and youth, especially because of the feeling of coherence, of this feeling of having other youth in the room had similar experience, going through similar struggles every day, and to learn from one another. I'm a great fan of group protocols, especially because in a way you can treat a lot of kids at the same time, so a lot of benefits with group protocols. But again, I'm afraid I'm not sure of a protocol that has been translated to Ukrainian, but teaching recovery techniques, for example, as CBITS and others, have been shown to be very effective for children and youth with different traumatic experiences. And also from TCBT, there's a group protocol. Yeah, apologies. Yeah.
Дуже багато слів подяки для спікерки і для Йорга. І нас дуже було багато, як завжди, що не може не дивувати. Це завжди і пані Оксану, і мене дуже дивує. І ми дуже-дуже вдячні спікерці Елайзі Pfeiffer за таку презентацію. Тема супер актуальна для України, і тому питань багато. Я всі питання не встигла задати, але вже 1,5 години пройшло, тому надаю слово Йоргу для того, щоб закрити нашу сьогоднішню подію.
Yes, I just want to thank Elisa Pfeiffer for that excellent talk. It was didactically excellent, but it was also heartfelt. It really came from your heart. I know you from your work, and you invested so much to train therapists. I remember how you developed a group therapy, a lay intervention for refugee children that you called My Way, where they could write down their narrative and work on it in groups. So for me, it was very, very convincing, and I'm glad that we invited you and had you here, and I thank you very much. And I wish you all a safe time, keep safe, and as much as we can, we are with you, and see you next time for the next webinar. Thank you very much.
Дуже дякуємо. Всім дякуємо, хто нас дивився. Всім гарного вечора.
Goodbye.